Assalamu alaikum. Thanks, Dr. Zahan, for your nice introductions, and thank you for the SSBMT committee for inviting me for this talk. My talk will be focused mainly on the adult experience of the CAR T-cell therapy at King Faisal Specialist Hospital. There's no conflict of interest for this talk, and there is unpublished data in this presentation. So as you know, the CAR T-cell therapy, it's work like as collecting T-cells or normal T-cells from a patient as auto, and it's get manufactured and gene editing, and then it's get 3 to 4 weeks to proliferate and then get infused to the patient, proceeding by lymphodepletion therapy, and it get causing apoptosis for the malignant cell that has the target for the CAR T-cell. So for in this slide, just to show how the journey of the CAR T-cell therapy get approval over many decades, and the green box or the green title here is just to show you the Saudi FDA approval for the commercial CAR T-cell product. In 2020, Saudi FDA has approved the T-cell for diffuse large B-cell lymphoma and for acute lymphoblastic leukemia up to age of 25, and in 2022 the approval for axi-cell for diffuse large B-cell lymphoma has been approved by Saudi FDA. So this slide, just to summarize what has been published, has been approved for the B malignancy as well as myeloma, the construct of the CAR T-cell and the co-stimulating, as well as the approval for these products. This slide as well, just to show us specific indications for each product. For example, if you see the T-cell, it has no approval for primary mediastinal lymphoma, while in axi-cell it has some approval. And if you go to the liso-cell, it has some approval for follicular lymphoma grade 3B. So that long time. And plexi-cell has an approval mainly for mantle cell lymphoma and adult BLM. That's for the third line and more of relapse. Later on, we have 3 well-known clinical trials that address the using of CAR T-cell therapy as a second line of therapy. So ZOMA 7 and Transform and Plenda study showing the positive study for axi-cell and liso-cell, while T-cell was not a positive study. So by these 3 clinical trials, the approval for second-line therapy for axi-cell and liso-cell has been established. So if you look to the data from CIBMTR up to 2021, you see how the numbers of the CAR T-cell increased, and indications as well, especially for the elderly population who has no or not fit for autologous stem cell transplantation. With regards of our experience in the kingdom, and especially at King Faisal Specialist Hospital and Research Center, it's actually started a long time ago, but because of some logistic issues of get approval of the commercial product, and without hiding the thankful for Dr. Al Ahmari from the pediatric. He was leading of the CAR T-cell at the institution with his team. So the CAR T-cell was approved, and we start the infusing for the T-cell for pediatric and adult. So from the adult sections, we try to establish guidelines. And as all of you know, with the experience that you pass through, when it's get to a new field, then you have difficulty to find the supportive materials. So we try to get a lot of materials through overseas from colleagues from different institutions to establish. This is actually draft book or booklet for the guidelines of the CAR T-cell therapy at King Faisal in adult section. So as all of you know, the King Faisal is established for a long time, and it has specific special interest for some of the rare diseases like oncology, transplantation, and genetic disease, as well as heart disease. I'm not going to spend a lot of time in this one, as all of you know. So in hematology at King Faisal, it has high volume of hematology and BMT program. Average inpatient was around 90 inpatient, and at one time last year, the inpatient reached up to 120 patients. You can see here this figure to see how they progress in the transplantation or in cellular therapy, and the green spot here or the figure here is just to show you the addition of the CAR T cell in the cellular therapy. This is part of our BMT and CAR T meeting that's launched every Tuesday. And this is the first CAR T cell therapy, or history of the CAR T cell started by this first patient. I think he is a patient of Dr. Al Ahmari from pediatric. So he was infused in January, it was in pediatric in December 2020, and the first adult patient was in January 21. So actually this is the first patient. He's my patient. He was 56 years old male. He has ABC, diffuse large B-cell lymphoma. He was refractory for R-CHOP 6 cycles. PET interim was NCR, then he has, because he has bulky disease in the inguinal area, he received radiation therapy. Then 2 months later he relapsed, so he was salvaged with ESHAP, but he has progressive disease. Then at that time CAR T cell was not approved in the kingdom, so we gave him another salvage. So he has some partial remission. Then at that time, before the CAR T cell kit approval by Saudi FDA, we start to apheresis him. And actually at that time, because it was the first patient, we were afraid that maybe the manufacturers will be failed or something like that. So we did for him auto collection for stem cell transplantation. In case the manufacturers fail, then we'll go for auto transplant in partial remission. So he received another, because we saw that there is a partial remission with RI-GIF, so we gave him another RI-GIF as bridging therapy after the collection. And then he received the T-cell as a CAR T-cell therapy. 2 months later, he relapsed after the CAR T-cell therapy. And you can see this is his first presentation before CAR T-cell, at the time of the collection. You can see how bulky disease he has. And then he has some, so he has a good control of the disease at day 30 of the CAR T-cell, but he still has some remaining disease here. So I gave him lenalidomide just to, at that time the ASH has a publication of lenalidomide. Lenalidomide has some immunomodulatory effect on the CAR T-cell therapy. So he had some partial remission at that time. So spent for him for around 3 months. Then he relapsed. He has from relapse. He came as ECOG 4, bit-bound. So he was given one dose of Bola-BR. At that time, Bola-BR still was a compassionate program. And then there was a bispecific compassionate program. He was enrolled in that compassionate program, which is glofitamab. So he received glofitamab. Thankfully, he achieved complete remission. So he completed 12 cycles of glofitamab. Then he was allografted from haploidentical donor. So this is the first patient. Actually, the CAR T was not the curative intent for him, so he required another modality. So what we are doing in our institutions, so we established the MTD meeting for CAR T cell therapy. So it's launched, and some of our colleagues from different institutions has presented their cases, which is in Sunday at 4 o'clock. So we do assessment of a patient, and then we will usually we do an MTD presentations. It has to have at least 5 consultants to do a vote for eligibility and taking decisions for the CAR T. Then there will be also in that meeting the apheresis lab colleague to be on the same field. Then patient will be booked for apheresis, and the choice of the product will be depends on the label indications as well as the disease entity. Bridging therapy also to be decided in that meeting according to the patient's need and aggressiveness of his disease or her disease. Then once the product arrived, usually we don't start lymphodepletion until we have the product in the institution arrived. So this is algorithm that's for any patient with diffuse large B-cell lymphoma. I'm not going to spend a lot of time as each institution, especially with the different consensus on that regards whether to take the primary refractory or do relapse within 12 months. So still it's debatable, especially with the cost effectiveness of the CAR T-cell in this field. So I think each institution has their own program or guidelines. However, I think we should have a national guidelines to have clear for all patients how we treat them, especially with this high cost and impact therapy. So this is also for ALL up to age of 25, and I think Dr. Al Ahmari from the pediatric will talk about the experience from the pediatric and the indications after one. So this is how the CAR T-cell is a bit complex, so it's need a lot of stakeholders from the patient, nurses, coordinators, apheresis, pharmacy, ICU, neurology, cardiology. So all specialties has their input on the CAR T-cell. So what we do when we started the CAR T-cell therapy, we try to do some of the collaborations, and some of the colleagues from different specialty has an interest. So we had an infectious disease specialist who has an interest for CAR T-cell therapy. So they used to see, or she used to see a patient before the CAR T-cell therapy by 1 week or so to clear a patient and look for the infectious issues in that regard. And then patient get admitted with some advice regarding the prophylaxis. When we started the CAR T-cell, we used to have our colleagues from the intensive care unit to round the patient on a daily basis, and the RRT nurses has to see a patient Q8 hours just to see the vitals. And then we did audit almost 6 months after we start the program, and we have a lot of patients, and we found that there is no need to continue seeing a patient in floor unless a patient reaches grade 2 of CRS. So this is just kind of repetitions what I have mentioned. Some of the issues for the fitness of the patient, we need to take it. Age is not, I think, a major impact, especially if there is indications for or label indications. Now, the age is keep increasing to be enrolled in the CAR T-cell therapy, and if you look to the ZOMA-1 study, the higher age was, I think, around 92 years old. So history of malignancy also important. ECOG performance status is an important issue, especially for the outcome, and the data supporting that issue. So ECOG more than 2 and higher DH has adverse effect on the outcome of the CAR T-cell therapy. Tumor burden as well has correlations with the toxicity, so we have to assess a patient for that, and using the best bridging therapy or decrease the burden of disease before that. Prior allotransplant has an issues with regarding washout period, active GVHD, immune suppression therapy. So all of this has to be taken in the patient fitness and enrollment in the CAR T-cell program. Some of the clearance, if you look to many institutions, there is no clear guidelines for that, but many of the data adapted from the stem cell transplantations, like infections, hepatitis, HIV, COVID-19. So a lot of things has to be, we try to manage it and look for different institutions, how they are doing, especially those who has good experience, and we try to merge it together and have a local or institutions-based clearance package or data. So some of the product has a specific issues to tackle, like hepatitis and HIV. So for T-cell, they have some prohibited things for hepatitis, while in axis-cell they have a different parameters. So I think for each product we have to establish what they needed for manufacturing. And for example, also for T-cell, high burden of blast, then it may affect the manufacture rate. This is just kinds of the CAR-T workup package we do it. I'm not going to go over them, but most of them is adapted or from the stem cell transplantations. We have 2 phases of clearance. One pre-apheresis workup phase, and the second one is pre-infusion workup. Most of the work is before the apheresis time. So one important thing, it was clearly illustrated and established with the some of product like T-cell. So you have clear guidelines for the washout period. So you have to look for that medications before you are collecting patients for CAR-T-cell. So, for example, if a patient behavior like high aggressive lymphoma, then try to avoid bendamustine. It has clearly affecting the manufacture rate and as well as the outcome of the CAR-T-cell therapy. Alemtuzumab as well. Allotransplant, there is no, you cannot avoid it if it has been already there. So, very important to have a washout period before the CAR-T-cell therapy, and I think part of we face some of the manufacturer's failure because of the washout period of some of the medications like bendamustine. So this is the table that we created for all patients. Has to be, I think, not well captured from the screen, but anyway. So you can see all of these medications in the literature for washout period should be tackled by the checked by the primary physician as well as the CAR-T coordinator to see if a patient received these medications or not. There's some specific parameters for apheresis for both products, whether for myeloma or lymphoma. So you need to look for that one before you send the patient for collection. Also, there is a washout period before lymphodepletion, like high-dose chemotherapy. If you are going to use high-dose chemotherapy as a bridging chemotherapy, then you need to manage it between the giving that bridging therapy and lymphodepletion. Intrathecal as well, it has a washout period as well as radiotherapy. So this is how looks the CAR-T-cell door at the level 19 at King Faisal. So we established kinds of poster for the ICANS and for CRS for the on-call staff. So they don't need to look for it on Google or something like that. They have to follow these instructions, and they have to contact the staff on call or consultant on call on that week or on that month on CAR-T-cell therapy. So when we start the program, as all of you know, we try to communicate with all of colleagues from different institutions as well as from the Gulf area, and I have to thank all of colleagues that collaborate with us and presented their cases, and I think that's so kinds of collaborations to establish patients' care in national-wise matter. So we received also some of patients from the Gulf country that has been infused at the institution, and I'll go over the how many cases that we have infused. So we started by T-cell in 2020. This data only for the adult, and I think Dr. Ahmari will present the pediatric data. So the T-cell we have infused 25 in non-Hodgkin lymphoma and 14 in ALL, and axis-cell when it's approved we have infused so far, not infused, but we have the data for 10 patients who passed 30 days use of the infusion. So you can see the median age in the axis-cell is 53 years, and T-cell is 48 years, and in the T-cell for leukemia is 18 years, and as all of you know, it's up to 25 years for the ALL. Male proportions is 30% in axis-cell, 64% in T-cell for lymphoma, and 78% for leukemia. ECOG, less than 80% in axis-cell. There are 2 patients who were before the CAR T-cell at the time of the collection. They were 2 of the ECOG, but because of the disease progress, they had some difficulty in ECOG performance, but we infused them and they are okay. In T-cell, all of the patients, ECOG performance is less than 2, as well as in leukemia. In lymphoma type, GCB subtype is 30% in axis-cell group and 52% in T-cell group. You can see here, this is the constructions of each product, as all of you know. If you see here the overall response rate and CR rate in axis-cell, actually this is a small number of patients, you can conclude from that, but the overall response rate is 70%, as matching the international data with CR rate of 50%. If you look to non-Hodgkin lymphoma in T-cell, 56 overall response rate and 36 CR rate. In the T-cell or for acute lymphoblastic leukemia, for the 14 patients, the outcome is CR. Actually, there's no overall response rate. All of them achieved complete remission. Some of them has some minimal residual disease. Actually, you don't have the data, but the CR rate is 92%. PFS, as you see it, we cannot conclude it from axis-cell because it's just short time. In T-cell for non-Hodgkin lymphoma, 1.7 months, and in leukemia, 10 months. With regard to the toxicity, 90% of patient has any grade of CRS in the axis-cell group, and 10% of a patient has grade 3 and above. And all of them were treated and responded to the therapy. We used prophylaxis of dexamethasone for 2 patients, and we used preemptive therapy, which is cohort 4 of the using prophylaxis of dexamethasone for 1 patient who has history of CNS involvement before. In CRS with T-cell and non-Hodgkin lymphoma, 88% of patients has any grade of CRS, and 12% of that population has grade 3 and above. In leukemia group, 57% of patients has CRS and 22 has grade 3 and above. Neurological toxicities or ICANS. In axis-cell, 30% has neurological toxicities, but none of them has grade 3 and above. In T-cell, 24 has neurological toxicity, and 20 of them they have grade 3 and above. So you can see on the right side of the figure the outcome. That's for the whole population with regards of subtypes of ABC and GCB type, and you can see the outcome is correlating or matching the international data. This is actually premature data for the axis-cell, and you can see there are three patients has follicular lymphoma, and the outcome is great. That's for 1 month, so we cannot conclude with that. And also the outcome, overall survival as well as PFS, comparable with what has been published, and at least what has been published in day 30 post-CAR T-cell therapy. This is for whole population with ALL and diffuse large B-cell lymphoma. The ALL with blue line, the overall survival is 100%, and PFS is around 80, and it's dipped down to 90, and dipped down to 80% after 12 months. And you can see here, this is the lymphoma, the overall survival around 75%, and the BFS is around 35 to 40%. So this is, before I conclude, I have to acknowledge our colleagues in all of the hematology department, stem cell lab, apheresis, BMT and CAR-T coordinating, cellular therapy quality departments, patient of course, and BMT fellow who has collected the data and analyzed it, also the other hematology fellow who has contributed in the collection of data. And with this one, I thank you, and if there is any questions, I'm happy to answer.